Okay, it's almost 11. I'm like, I'm starting.
I know. I said it's a little early, but I'm like, I'm gonna go eat my yogurt because I'm about ready to eat an hour and a half.
Good morning, and thanks for joining us for the Readmissions and Care Transitions Community of Practice. If you're joining us a bit early, we appreciate you being here. Please do mute your phone lines so we don't hear your background noise as you enter the meeting space. We'll be starting momentarily. Good morning, everyone. This is Kate Carpenter from the Iowa Healthcare Collaborative, wanting to welcome you to our August Readmissions and Care Transitions Community of Practice. We have a great presentation planned for you today on Grace Team Care. It's 11 o'clock, and without further ado, we're going to hit the road. We'd like to start off with a few housekeeping items. We'd love for you to tell us who is in the room today. So if you can use the toolbar to navigate to the chat box, we'd love for you to type in a message letting us know your name, the role that you're in, and which facility that you represent. Additionally, if you would take a moment to mute your phone if you haven't done so already, this will help us eliminate any background noise during today's presentation. A reminder that if you have dialed in with your telephone, please don't place the call on hold today if you need to step away momentarily. Oftentimes we will hear your background music. We encourage questions throughout the session and love your discussion. Staff will be moderating the chat throughout our event today, so please do utilize the chat box to type in your questions and comments as you have them throughout the presentation, and we will address all of those during the open Q&A time. Okay, as we get started here, I'd like to let you know that we are presenting on Grace Team Care, and we have Don Butler and Carrie Ortwine with us today to present. As we get started, I'm curious, and I'm getting ready to launch a poll. I'd love to know how many of you have heard of Grace Team Care. You should see that poll starting to pop up on your screen. Please let me know in the chat box if you're not seeing it come through. We just want to know, yes, you've heard of Grace Team Care, no, you haven't, or you've heard of the name, but you're not quite sure what it means. We'd love your responses here as I introduce today's speakers. Dawn Butler. She received her Bachelor of Social Work from Indiana State University and Master of Social Work from Indiana University. Mrs. Butler received her law degree from the Indiana University Robert H. McKinney School of Law. She began her social work career in long-term care, serving as the Director of Social Services in a 200-bed long-term and subacute care facility. Mrs. Butler was one of the first social workers to join the original GRACE program and served in this capacity for 7 years, a span that included the research trial. Upon completing her Juris Doctorate, she worked as an associate attorney for a general practice firm before returning to IU Geriatrics in 2012 to serve as the director of the newly established IU Geriatrics GRACE Training and Resource Center. The goal of the GRACE Training and Resource Center is to provide training and technical assistance to organizations interested in implementing the GRACE model. To achieve this goal, the center provides a range of services from consultation, webinars, on-site training, and offers a variety of program tools. As the director of the center, Mrs. Butler provides direction and leadership in the development, implementation, operation, strategic planning, and public relations of the center. She also designs, implements, and coordinates dissemination and training programs to prepare healthcare professionals and organizations to implement GRACE Team Care. Joining her today is Carrie Ortwine. Carrie received her Bachelor of Science in Nursing from William Patterson University in Wayne, New Jersey, and her Master of Science in Nursing from the University of California in San Francisco. She worked in a variety of clinical settings as the geriatric nurse practitioner, including long-term care, outpatient geriatric consult clinic, and home-based primary care. She has additionally been involved with the GRACE model of care since the pilot study phase of the original research study started in 2001. Carrie was instrumental in developing the nurse practitioner role in this innovative care model, and after the conclusion of the original GRACE research trial, she became involved in the initiation and dissemination of GRACE in the Indianapolis VA Medical Center. She was involved in the training and dissemination of the care model in an additional 3 federal VA sites, including San Francisco, Atlanta, and Cleveland. In 2014, she became the GRACE team lead at IU Health System, in which she directs the clinical operations of the team in addition to ensuring integration and implementation of complex care management programs within the MA plan as well as IU Health System. In addition to her clinical work and leadership in the GRACE program in 3 health systems, she's been involved in the training and dissemination of the program in over 20 health systems in 6 states. Gals, we appreciate you being with us today. The floor is yours.
Well, good morning, everybody. Thank you so much for letting us come and be a part of your day. We are very excited to be with you today and to share with you regarding the GRACE Team Care model. Just looking at the poll results, it looks like about a quarter of us have heard of the GRACE Team Care model, but the vast majority have not. So that's wonderful. We actually like to see that. So we're going to take it from the top and walk through our model and some of our results. So next slide, please. So our hope today is to do a couple of things. First is to talk briefly just about older persons who stand to benefit most from integrated care. We will describe the GRACE Team Care model and some of our results. We'll discuss some of our lessons learned from the replications of GRACE, and then finally review some of our training and technical assistance that we have available. Next slide, please. I know that many of you have had some prior webinars that have discussed integrated care and really the current practice of that. And so I'll kind of briefly go through this. But as many of you know, in the past, it was primary care was really offered by a kind of traditional office-based primary care physician. And that moved really into the patient-centered medical home, where there was oftentimes a nurse care manager or some transitions that were assisted by either a nurse or a social worker for those that were transitioning between levels of care. And the future, which is really what we think we are now, is really this focus on high-intensity care management, these really home-based teams that are combining the nursing as well as social work with transitions that have the addition of an APN role. And that's really where the GRACE Team Care model fits in. Next slide, please. So a Lewin Group report from 2010 that, although I can't believe it's been 7 years ago, is still really very apt, I think, for the work that we're doing. But what they found was that older persons that have chronic diseases and functional limitations need more medical services and social supports, oftentimes suffer from a variety of geriatric conditions, have socioeconomic stressors and low health literacy, as well as limited access or fragmented health care. And again, I know I'm preaching to the choir a little bit, but this is the cohort that really has very high healthcare costs, where 20% of these adults that have these chronic conditions and need help in their ADLs or IADLs represent over 40% of all healthcare spending. Next slide, please. So what does this cohort look like? Well, these are the older individuals that have multiple chronic conditions: hypertension, coronary artery disease, CHF, diabetes. They may suffer from a variety of geriatric conditions, dementia, falls. They have some family and caregiver support needs. They may be receiving some services from home or community-based services. They oftentimes are seeing a primary care physician as well as a host of specialty care physicians. And they oftentimes are being seen in healthcare settings where it's very difficult to have communication and coordination of care. And as we know, a lot of healthcare providers don't oftentimes have a lot of experience or expertise in working in geriatrics. This is really the population that we really target for the Grace Team Care model and really try to focus our attention since the completion of the original trial. Next slide, please. And Kate, can you go ahead and drop that second poll question? All right, so a polling question has popped up for you, if you could. So what do you see as lacking in your health system when you're caring for the most frail patients? Just try to get a sense of what are the things that you're most concerned about when you think about complex care management. Kate, can you show the results? All right. Yeah, so as we suspected, yes. So the primary concern really is that fragmented care and working in silos. We can certainly appreciate that. Lack of care coordination and no geriatric program for sure, about a quarter of you, and some of you seeing the lack of transition care. These are elements really that I think Grace can help assist with as the model begins to really focus in on these issues through its steps. And with that, I'm going to turn over to Carrie to talk through the steps of the Grace Team Care model.
All right.
Next slide, please.
Next slide. All right, where's my pictures? Okay, so Grace Team Care, this is a brief overview. First and foremost, we do an in-home geriatric assessment with the nurse practitioner and social work team. That is the main dyad of the team. From there, we go back and individualize care plans using our Grace protocols, which we will touch on in a few minutes. We don't get into the primary care issues, you know, like hypertension and diabetes, and that we stick to our Grace protocols by and large. From there, we then meet weekly with our interdisciplinary team. That's the bigger Grace team that doesn't go into the home, but that you meet with regularly, weekly. And that includes a geriatrician, a pharmacist, and a mental health liaison in our case. In the past, we've even had physical therapists and community resource specialists in this team. But it seems the pharmacist, geriatrician, and mental health seems to be what we have evolved into. Next slide, please. After the team conference and we develop our care plan, the nurse practitioner and the social worker then meet or discuss with the primary care physician. And this can be done a variety of ways depending on your health system. We currently kind of do this through the electronic medical record now versus going physically in person. This is where you're kind of teasing apart what things you would like to work on and ensuring that the doctor is on board with your recommendations, kind of prioritizing and moving forward with the care plan after you meet with the primary care physician. So then you go back out, you meet with the patient and the family and caregivers and discuss the care plan. And so what might be your priority may not be the patient's priority. So always trying to work around the patient's goals and keeping your care plan consistent with those goals. From there, you introduce what you would like to do with the patient and hopefully get some buy-in. And from there, you kind of get started with implementing the care plan suggestions. From here, then you're providing ongoing care management and caregiver support. You see the patient in intervals, and depending on the priority of their needs, how frequently you may need to see someone. A lot of telephonic support that we provide as well. Trying to coordinate all those pieces, like you had mentioned, the silos. So trying to draw all those together and provide ongoing care management around that. Ensuring the continuity and coordination of care and smooth care transitions. So always being in tune to who's in the hospital and the emergency room and that sort of thing, so that you're making sure you're getting out to the home in a timely manner for those transitions is really important.
And one thing, as Carrie was discussing that first step of that in-home geriatric assessment, so one thing that I wanted to mention with that is that this in-home assessment is done by the nurse practitioner and social worker together, as she mentioned, and it's really a geriatric-focused assessment. So the nurse practitioner does really extensive medication reconciliation, looking at functional status. The social worker will do a home safety evaluation. They also together will do a depression screen, a cognitive screen, as well as a caregiver burden assessment if that is applicable as well. And those assessments, again, are really kind of really tuning the team into the geriatric syndromes and those issues that in particular primary care may not be aware of or may have missed. And so as Carrie said, then developing that care plan to really complement the primary care role, looking at more of those disease management types of conditions. So next slide, please.
So here's the protocols, and then just the titles of them, not all the actual implementation of them. But so you have advanced care planning, health maintenance, and we do those two, as well as med management on every patient at a minimum. So very rarely do you just have those three, but those are our three mainstays. We have difficulty walking and falls, depression, dementia. Caregiver burden is a huge piece of what we're doing as well. Chronic pain, weight loss, incontinence, visual impairment, hearing impairment. So those are the protocols that we work off of. This is an example of a protocol for our difficulty walking and falls. So one piece is that you're reviewing with the primary care directly, making sure that the diagnosis is in the EMR. Frequently we find that the diagnoses are missing, especially around dementia. Sometimes that's not even mentioned in the patient's record, but and they have that. Walking falls, frequently not mentioned as a diagnosis in their EMR as well. So confirming that, evaluating treatment and cause, or evaluating and treating causes, I read that one, is part of what we do. So any laboratory work that hasn't been done already, recommending that be done. Any other imaging or anything around the walking falls, this is where you would recommend that after you've looked through the EMR and made sure what has already been done, so you're not asking to duplicate anything. In the case of walking and falls, you might need to optimize pain medication, get some recommendations around that, possibly a physical therapy consult. There's usually other consults here with walking and falls, such as making sure they're going to the eye doctor, maybe the podiatrist, getting a hearing evaluation. All these things kind of factor into walking and falls as well. Maybe you need a consult with a neurologist if you suspect something else is going on, maybe a Parkinson's or something like that. So this is where you're really, the nurse practitioner in particular, is digging in with the primary care and kind of prioritizing the evaluation of the syndromes that may have been overlooked. The routine team interventions, this is not necessarily something you need to run by the primary care. This is just sort of what we're automatically doing. And that's the education piece, monitoring, orthostatics, increasing fluid intake, kind of walking them through walking programs and, fall prevention education, looking at the home, any modifications, recommending that. So that's just where you don't need to, take up the primary care time with that, just automatic intervention.
One thing about the protocol, as you can see, as Carrie kind of walked through that for those of you that maybe are familiar with the checklist manifesto book, that this is really how the protocols were designed, that it was an effort to really bring together kind of all of the best evidence-based recommendations for these particular syndromes, so that as Terry was walking through then, you can really see that the teams, once they've identified a particular issue, can then go to the protocol and begin to identify, well, which of all of these recommendations are the most applicable to this particular situation, and would help the patient achieve their goals. And they can then simply kind of activate these particular suggestions based on their assessment findings and the patient's goals. And as Carrie said, then reviewing that closely with the primary care physician. Next slide.
Yep. Okay, so the transitional care is a big piece of what Grace does. Like I said, we are always trying to prevent hospitalizations and ED use that's unnecessary. So, you know, in your own system, figuring out how you determine who has been in the hospital or the emergency room is important, or working with families to alert you when this happens, just so that you're aware. From there, you're tracking them to see how long they're in the hospital, you know, ensuring that you're going to get in the home within 2 to 5 days of them being home. When they're in the hospital, you can communicate baseline status to providers in the hospital. Frequently, there's a lot of missing pieces for them. They too are somewhat in the silo, especially if caregivers are not available at the hospital. You know, they might assume someone is demented and doesn't function well, who may be just delirious, who actually does fairly well, or just the caregivers that are involved in how to plan for that. So this is where Grace, you know, can really help fill in some gaps with the inpatient team as far as what you've been working on, so they don't start working on things that you already have in process as well. So then collaborating that transition home as necessary. Just being in tune, making sure that they're going to be, you know, discharged to the appropriate level of care, and that if it is coming home, that things are in place to accommodate that. So at this transitional care home visit, that's where you kind of go outside the Grace model geriatric piece, and you focus more on the medical piece that drove the patient to the hospital. For example, if they went in for CHF, this is where, as the nurse practitioner at the transitional visit, I'm going to focus on CHF. I'm going to make sure, you know, that the patient is aware of the signs and symptoms, what to do if there's an increase in symptoms, that the medications have, you know, been adapted. They're at home for the new regimen. Reconciling the meds at the transitional visit is a very top priority at this visit. As we know, frequently things change in the hospital. They come home and maybe they fire up all the meds that were there before and the new ones, and sometimes there's formulary issues, duplicating, and various things. Maybe they didn't get the antibiotics filled, making sure that that is happening. So the medication piece at transition is very important. This is also a time at transition to make sure that the discharge plans have actually been implemented. Is there going to be home care? Is there PT? Have they contacted the family? Did that get dropped somewhere? And that's something Grace can pick up and make sure is happening. You want to make sure they have their follow-up appointments, whether it be with a specialist, if it was something with the heart or the primary care or neurology, whoever needs a follow-up visit with them post-hospital, ensuring that that has been scheduled, that they have transportation to get there. The social work's very helpful in navigating that, and just making sure that they should be home, they're at the right level of care, and making critical decisions at that time if there's some other intervention needed, or if they're safe, if they need to go to a subacute. We've had to do that before where they're just not going to make it there at home. But so the transitional visit is a very important visit in the Grace model. Then we would review that as an extra review in our team conference that week with your larger team as well, to kind of come up with recommendations if something's not in place. Next.
Yeah, and your next
slide. Yeah. Oh, are these questions? Should I go ahead and get the case? Okay, so I brought a case example of a transitional visit to illustrate all the complications that you can see. And so I'll launch into that. This was a 74-year-old Caucasian woman who was living with her son who has a head injury. She isn't a hands-on caregiver for him, but she has to manage his medications and finances as well. She had been hospitalized 2 times in the past year and had been to the emergency room 1 time as well prior to this hospitalization. Her past medical history includes coronary artery disease, CHF, COPD, hyperlipidemia, diabetes, hypertension, anemia, and a history of breast cancer. So she pretty much hit all the big diagnoses there. She was on 19 medications, including Xanax and Norco. Her hospital stay was for 16 days this particular time. She had originally been admitted for nausea and vomiting, which led to a fall from dehydration. She then, unfortunately, in the hospital had a heart attack, which then threw her into CHF. She also had a GI bleed during this hospitalization, hence why it was 16 days. It was a very complicated hospitalization. She had a heart cath done and had a drug-eluting stent placed at that time. She had a colonoscopy done during this hospitalization, and there was multiple med changes made in the hospital as well. At discharge, she went home rather than to a subacute. She was a pretty feisty lady, I must say that, and she was ready to rehab it at home. So we were giving her that chance. She had good support out there. So PT and skilled nursing were ordered at discharge. At the time of my visit, the RN had already made her first home visit for the home care. And so she had left her med list and been over some maintenance items with her at that time. So when I got there, she was still reporting feeling very weak and fatigued. She didn't have much appetite, had nausea, had constipation. She'd been taking her Xanax twice a day, 0.25 milligrams, and her Vicodin 3 times a day. Her blood pressure was 84/40, with 73 heart rate sitting. She was 92/40, 72 standing, 93% room air. She had 1+ pitting edema to her mid-shins. She had difficulty rising, and her gait was very unsteady. She looked ill-appearing to me. She was very worn out. On my med rec, I discovered that she had been taking 10 milligrams of lisinopril, which had been reduced to 5 milligrams. Her metoprolol was ordered for 12.5 milligrams twice a day, and she was taking 100 milligrams q-day. So I'm seeing her on day 3, I believe. So she had been taking those meds for the 3 days. So that's markedly increased, especially on the metoprolol. So that is reflected. Her heart rate was maintaining, but her blood pressure was down, and the weakness was very profound. So this is after the RN had been there. So she too had an inaccurate med list. Somehow that happened. And so at that point, trying to keep her out of the hospital, anticipating if she has to go back, how involved that they would be, not recognizing that maybe she had taken those meds wrong. They would probably be oblivious to that in the hospital. So I corrected her med box, had to go through and empty it and, refill it. I called the RN that was coming out and her granddaughter who oversees. I faxed them new med lists. We got telehealth set up for the next day. And then we just sort of watched and waited and went through all the signs and symptoms if she was, to have that she would need to go back in. And we hoped that, the reduction in meds and holding those doses for a day would, she would recover from that, which she ended up doing. So she stayed home. I imagine if she had one more day with those meds as such, that she probably would have had to come back in. So she got her PT, and her follow-up with cards and primary care were within the next week as well. So that's an example of a transition visit where the medications did not translate from the hospital even to the home-based RN to the patient. And a granddaughter was a caregiver who was filling her pill box, so she too had missed the cues for the med changes at that transition. Next slide. Great.
All right, we'll pause there, and I think maybe take some questions about the model that it may have come in before we get into some results. So, Kate, can I turn it back to you for any questions that have come through?
Thank you. Yes, there's been a flood of questions coming in through the chat, so I'm going to start at the beginning and we'll answer some of those. The first questions relate to the home visit and wondering who pays for that in-home assessment and if it's a contracted independent service or are the social worker and the NP employees of the clinic or the hospital?
Those are great questions. So our GRACE teams are all employed by the individual health systems. So they do not work as contract employees. And that was actually a very deliberate part of our dissemination. When we work with health systems, we really encourage the employment of our GRACE teams by the same group that is employing the primary care practice providers and staff, so that our GRACE team should really be seen as a colleague of, an extension of the primary care offices. And part of that was really helping to ensure that they were wearing the same logo on their polo shirts as the primary care clinics were as well. As far as who pays for the in-home assessment, that varies greatly depending on the health system and what their finance mechanism is. We do have a few of our GRACE programs that operate in a fee-for-service market, and some of them do then just bill their service. Certainly, as you all know, that the billing for an in-home assessment is certainly not going to be enough to sustain the program. They can't sustain purely on a fee-for-service environment. Our nurse practitioners are the only ones that bill. We do not have any of our GRACE programs currently that have their social workers billing, although that is something that many are looking into. Other programs or other health systems operate more in a capitated network or are an ACO or a Medicare Advantage plan, in which case those systems just assume the cost of the team because of their impact on the cost utilization is so significant that they really kind of pay for themselves and then some. So some of them do not particularly bill for their service, but that is highly individualized depending on the system they're working within.
Thank you, Dawn. The next question is, so are the protocols you're talking about similar to standing orders that the nurse practitioner initiates?
Not exactly. The protocols are based on best practices for geriatric syndrome evaluation and treatment. So they're very similar and probably maybe exact to the American Geriatric Society recommendations for the management of those particular issues. So if you read them in their entirety, they're very, everything is in there. They should be tailored to your patient though. It's the guideline for things to be thinking about in the face of depression, those are the labs that are recommended to rule out, other factors. So you pick and choose which parts of the protocol are applicable to your patient. So it's not just you click it and you do all of them. They should be tailored still.
Thank you. Next question. If services are needed, do you refer the patient to a home health agency or are you providing the care once a home care agency is in place? Do you still make visits to evaluate periodically? And then in addition to that, do you actually set up medications for the patient and instruct the patient about their medications?
Is that written out? Make sure I get it. Okay. So I'll try to answer this. I'm terrified going back 3
And
weeks.
I can do the
first. Okay, do that first.
So this is Dawn. I can answer the home care part. So GRACE refers out to home health care services. Our model is really meant to, we do not superimpose home health care. We do not operate as a home health care agency. Many of our patients do receive home health care as well as GRACE. For example, we may have patients who are receiving physical or occupational therapy in the home, or maybe having some nursing services for wound care therapy, for example. So our GRACE team is referring to home health care for that. Our GRACE team, as Carrie was mentioning about the care coordination and that communication, we really kind of set ourselves up as being the hub of all of that communication. So they really try to closely connect with any of the services that are in the home, if it's be home health care, home and community-based services, Meals on Wheels, anybody else that's sort of working with the individual. helping to try to keep everybody all on the same page, include with the primary care provider as well as other providers involved. So we do refer out to home health care, and the team will continue to see. We work very closely with home health care. As you can imagine, we're collecting some of the similar information that they may be collecting, and so we try to have very close working relationships with home health care to share that information. Many of our home health care agencies actually enjoy having GRACE patients because they know that they can really kind of readily get information about medications and have a great connect, having someone like Carrie, a nurse practitioner that they can connect with to help sort of triage information and help be a connect to primary care.
So we would always continue to do GRACE visits even with in-home care through an agency. It depends on your program, how often that's happening, or the priority of if you feel like you should go out more frequently or not. But you don't back out ever, even with them. As far as the meds go, a big piece of what I try to do, I'm always making patient-friendly med lists and encouraging patients to use pill boxes. They don't always listen to that, but I try to get them to do that. So I will do a lot of setting them up, but in a teaching mode, either with a caregiver or the patient, trying to get them to be able to do that autonomously. And then I will work with the home-based RNs if they are involved, trying to, further support that effort as teaching the patient or the caregiver how to do the med management as safely as possible. But I don't myself go out, bi-weekly or anything filling pill boxes. But I wish we did have someone that could do that indefinitely. It would be very needed. So it's mostly around education with the medications for me.
Thank you both for answering those questions. At this time, we're going to go ahead and proceed with the presentation. Please continue to send in your questions, and we'll address those at the end. Thank you.
Great questions. No, thank you. Next slide. We're going to walk through some of the results of the GRACE program. So GRACE, as we mentioned, started out as a research trial. It was designed and tested by Dr. Steve Council and his colleagues and researchers here at IU Center for Aging Research. The study was conducted at Eskenazi Health, formerly known as Wishart Health Services. It's a public safety net hospital system here in Indianapolis. And for the research trial, all of our patients were enrolled for 2 years, and we really enrolled all comers. So anybody that came into one of the designated primary care clinics who was over the age of 65 and had a telephone was enrolled in the GRACE study. What we found from that GRACE trial was that really everybody that had received the GRACE intervention benefited. We had better performance on some quality indicators, in particular in areas of general health care and the geriatric conditions. We also found an enhanced quality of life in looking at general health and vitality and many of the mental health component summaries of the SF-36 scales. When we drilled down, though, what we really realized is that those individuals that were in the high-risk group, so those that were most at risk for hospital admissions, that's where we really found the lower resource use and the subsequent lower cost. We found fewer emergency department visits and hospitalizations, and we found that these acute care cost reductions really offset the program cost. As a result of this, this is really where we began to tailor our GRACE program away from all comers really into that high-risk group. Next slide, please. So this slide, what particularly I want to point out is, as I mentioned, the GRACE trial was for 2 years. And what we found when we looked at hospital admissions for those high-risk patients, we found that even at year 3, so a year after the completion of the research trial, that there still was a little bit of a prolonged effect in the reduction of those hospital admissions. So it's something that we have really been continuing to kind of monitor, is this sort of halo effect, that even though the teams may discharge a patient, that there was some ongoing benefit even in that 3rd year. Next slide, please. And this is really, I think, a lot of why the GRACE is getting a lot of attention, is that, as I mentioned, the lower cost, that from the cost of the intervention was really offset by the reduction of those acute care utilizations, and really then some. Next slide, please. So oftentimes we're asked, well, what's the secret sauce? What makes GRACE successful? And we really think that it boils down to Carrie and I. Oh, sorry. Definitely. I think it really boils down to these 7 keys to success. The first is that our nurse practitioners and social workers are assigned by physician and practice site. And this is really done deliberately in the beginning to try and connect our GRACE teams very closely, have them really closely associated and aligned with those primary care practices. The second is, as Carrie was talking about, this will focus on geriatric conditions and medication management meant to complement and support primary care. As she discussed with our GRACE protocols, we don't really talk about managing diabetes and CHF. And really that's based on our perspective that, you know, if you have an older adult whose diabetes is out of control, it's not because the primary care doctor doesn't know what to do. It's because there's oftentimes all of these geriatric conditions that are going on. They may have a lack of resources to food or medication. There may be a visual impairment, so they're having difficulty taking their medications. They may be depressed and not taking care of themselves, or there may be a cognitive impairment as well. And all of those really fall into the purview of our geriatric conditions. And what we have found is that if we can focus our attention on those particular conditions, we really have a crossover effect of being able to help manage those traditional, more disease management types of conditions. The other key to success for GRACE is that we really provide those recommendations from care, as Carrie was reviewing, and then provide the resources for implementation and follow-up. Our GRACE protocols are all written within the scope of practice for our advanced practice nurses and our social workers. So anything in those protocols, our teams can go ahead and do, and they can then follow up and make sure that those are implemented. We have incorporate proven care transition strategies, as Carrie was talking about the pillars that we walk through during our transition visits. Many of that is based on the Mary Naylor model with the incorporation of a social worker. Another key is this real home-based aspect. And again, I know I'm preaching to the choir when I say, you know, going out into the home, you really get an opportunity to see what's the rest of the story. The curious patient that keeps falling and no one can figure out why, and you spend about 2 minutes in their home, and it suddenly becomes extremely evident why the patient is falling. And also this idea of proactive care management. As Carrie was saying, their continued focus on keeping in touch with their patients and proactively trying to see them. We try to set up a system so that something doesn't have to be wrong before they hear from our GRACE programs, but that rather we can begin to get ahead of any particular issues or concerns. The integration of community resources and social services, helping again to kind of pull everybody that's working with a particular individual together. And then the idea of really developing our relationships through longitudinal care. The GRACE team was not set up as a short-term or a SWAT team approach where we can get everything done in 30, 60, or 90 days, but rather we feel that you develop relationships through the longitudinal approach and having an opportunity to really get in there and get at the heart of some of these conditions that we've discussed. Next slide, please. And next slide. So we talk a little bit about just some of our replication work. As Carrie mentioned in her initial bio, the research trial was from 2001 to about 2007, 2006. Since then, we have been working hard to implement the GRACE model in other health systems. On the slide that you'll see in front of you just shows the first 3 replications we did, and really just shows you the kind of the breadth of kinds of populations that we have served in setting. Home-based primary care, more of an office-based primary care, and helping both to kind of complement and support those. Next slide, please. Our first replication outside of our Indianapolis area here was with a group called Healthcare Partners. They're a large medical managed group in Southern California. And as you can see here, they were really targeting frail older adults. Their average age was 85. Many of them were enrolled already in their home care program, so they were already at high risk for chronic care. They took the GRACE model and really interlaid it within their home care program. So they already had a physician and a nurse that were seeing patients that were homebound, and they took the GRACE model and really helped to implement that into that particular program. What they found is that patients were highly satisfied with the GRACE model. There was an improvement in quality of life. Many also felt from the provider side that it was helpful for them in providing care to their older patients, and they found that it really was helping to lead to better follow-up and coordination of care. Next slide, please. And this just shows some of the quality improvements in the outcomes. They had really significant reductions in utilization in areas of hospital admissions, number of bed days, as well as their subacute admissions and ED visits, all had a tremendous reduction. They also looked at some quality indicators for falls and medications, as well as surrogate decision makers or healthcare representatives. And greater than 95% of the people that were enrolled in this particular program had been screened, received med lists, and had a surrogate decision maker documented. Next slide, please. And this is just, again, kind of a visual graph to show you the reduction of each of those particular areas of hospital admissions, subacute, and ED visit, showing just a kind of a simple before and after approach on looking at our data. Next slide, please.
So at the VA, we took a little bit different approach, recognizing that the high-risk patient is who would be best served by the GRACE program. So at VA, we targeted those patients that were in the hospital. That was their initiation into the GRACE program. So by and large, we captured quite a few sick older adults by that mechanism. So we saw over 500 veterans and 300 caregivers were served in the program at the VA. What we added, they had a home-based primary care program there, which was RN driven. But what we added, which was different, was more continuity and coordination of care, the medication reconciliation and appropriateness of medications was a big piece of what we brought to the VA. We actually impacted the culture of the VA, I would say, in Indianapolis anyway. There was a lot of Ambien being prescribed to patients. Everybody had Ambien. Very fascinating. So we really were getting big on trying to, not prescribe inappropriate medications to older adults and kind of coming at those problems in a different way. And I would say over the course of a couple years there, we weren't seeing Ambien anymore being prescribed. So the medication piece is huge, what you add to the system back with a geriatric focus. Falls prevention, depression management, that was a huge piece there too. Getting people diagnosed appropriately on medication and monitoring the medication, titrating up, those sort of things. Dementia identification and management, another huge issue. Sometimes primary care, patients can pop in with them, they have 10 minutes, they can, confabulate and hold it down for 10 minutes, but when you're in their home after about 15, it becomes apparent that there's a cognitive issue here, and really identifying those patients and getting them the treatment they need, caregiver support. So these were things that weren't by and large happening at the VA, and GRACE brought that to that health system. Next slide. And so here's the results from the VA. We reduced the 30-day readmissions by about half, as well as, those are days, right?
Yeah, admits per 1,000.
Yeah, admits per 1,000. So we just decreased overall hospitalization rates as well by almost half, looks like. Yeah. Next slide. I can read this. Okay, so here's what a veteran said. I'm sure they were talking about me. I am amazed, not really. I am amazed at how you guys keep track of me. Grace is amazing. I surely do appreciate you guys. You are a great team to have caring for me. Caregiver response as well was, the Grace team saved my husband's life and my sanity. I had hit rock bottom when the team came to our home and didn't know how we were going to continue like this. The entire team is warm and sensitive to our needs. I would like to thank Grace from the bottom of my heart for giving me my old husband back. The primary care physician response could be, or was, thank goodness Grace is involved on this patient. And I have found that most primary cares are receptive. These are very complicated patients for any one person to try to manage. At IU Health, the current health system I'm working in, we don't specifically get patients from the inpatient setting, although we can get them enrolled via that mechanism. We get a lot of primary care provider referrals to the GRACE program in this MA plan that we are currently in. Still targeting the high risk. Sometimes we get patients that aren't as high risk as should be for our program, but I think we still do impact them as well. And as you can see, the same model of care, ultimately showing the same results in the IU Health system, reducing 30-day readmissions by almost half, a little bit over. And same with admissions overall, reducing the rate of admissions as well.
Next slide. Yeah. So in IU Health, they operate under a Medicare Advantage plan. So we looked at kind of a pre-post test. And as you can see here, again, fairly consistent results. And what we're finding across our replication sites is significant reduction in inpatient admissions. Total cost of the patients were found down. What's interesting about our Medicare Advantage plan is that when we looked at the data, we not only had an impact on the utilization of those acute care services, but we also found that we were able to increase the per member per month payment to the health plan. And this was really coming from our use of our nurse practitioners on being able to, while they're out in the home and doing those initial and home assessments and work, they're capturing diagnosis that otherwise would have been missed or maybe overlooked. And because of that additional diagnostic capturing, we were able to increase the premium pretty significantly, about 11% improvement. So this was really a really positive business case on being able to show not only reduction in utilization, but also an increase in the payment to the health plan. Next slide, please. And this is just a snapshot of the business case for Grace, and certainly recognizing that this is going to vary. This is my disclosure legally that this will vary by site. These results not typical. No, these results are typical, but will vary by site. What we find with Grace is that really when operating at an optimal level, they would run 3 nurse practitioner social worker dyads, and those 3 NP social worker dyads can be supported by 1 full-time program coordinator. Other members of the team, as Carrie mentioned, that geriatrician or medical director, the mental health liaison, and the pharmacist. We generally account for about 10% of their time. This allows them some dedicated time each week to attend the weekly interdisciplinary team meetings, but then also be available periodically throughout the week to answer any questions or be of additional support to the team. Our caseloads operate at about 100 per NP social worker dyad. So if you are operating 3 NPs and social workers, we anticipate a caseload of about 300. Our average cost is about $630,000. Again, this would vary by site depending on, this is based on an Indianapolis or Midwestern market. What we found pretty typical across our sites, though, is the reduction of savings. Pretty standard, about 30% reduction in hospital admissions. And as I mentioned, for those particular health systems that also have an opportunity for some enhanced revenue, we have found about a 10% increase in premium. So the Grace team is really able to cover their costs and then some, as well as bring in additional revenue. Next slide, please. We've spent a lot of time looking at the business case for Grace, but we also had the Avalier study that was done in 2014, where they did an independent analysis of Grace and found that we had a 95% return on investment. And what they really focused on, I think this is a key, is that effective management of those key populations. So older adults with multiple chronic conditions and functional impairment, that cohort that we are really trying to target can not only improve outcomes for the plan members, but can also yield a positive return on investment. And we think that's really key because as we begin to think about complex care management, that it's looking at the program and the impact on the patient level, but also thinking about that from a business case. And what Avalier found through their independent analysis is that these kinds of programs can yield a positive return on investment. Next slide, please.
So as far as the Grace case example, I was just going to point out, what makes Grace unique compared to other programs. I mean, we've all heard of care management programs out there, but what sets Grace apart for me is a couple different things. One is that it's geriatric focused. That what we know is that a lot of times primary care physicians simply just don't have the time to get into all of these things. A lot of time is spent on diabetes, COPD, hypertension. But what about that dementia? What about the falling, the weight loss, the depression? So we add that whole piece of the geriatric focus to this. We're providing complex care management. So we go beyond disease care management, which has its place as well. COPD, CHF, yes, we're touching on that, but we're also trying to coordinate and manage across multiple specialists, not just multiple diseases. So that's a unique feature too. All the different transitions and continuum of care that these patients are going to encounter, kind of having someone as a quarterback, so to speak, is helpful for this super complex group. The third component that I think sets us apart is that transitional care piece. Everybody, is always wanting the transitional care program, and generally I find them to be short term, 30 days, 60 days. So GRACE is in place, and we do that as well. We add the transition piece. It's a huge part of what we do. It actually takes priority over many other visits when someone's in the hospital, because we know the return on that is so great and so needed. So those three pieces are very unique to the GRACE complex care management. And then obviously having a nurse practitioner versus an RN, there's a lot of discussion around that. Do you really need the MP versus the RN? And in my opinion, I think that you do for this intensive group. You know, the MP is able to diagnose and to order and evaluate within their scope of practice as well. So that takes burden off the primary care physician to just, you know, tell them what needs to be. You can actually proactively help them by managing it as well. So it lowers their burden. The medication piece is so complex with these patients. Having a nurse practitioner really dig into that and help reconcile, de-prescribe, and also prescribe when needed is very valuable to this program and sets it apart from other programs as well. The social work piece, having that dedicated social worker to these patients is very important. Frequently, social workers, at least in our health systems, you know, they have hundreds, if not thousands, of patients that in theory they're supposed to be helping. When you have patients like this, their social determinants of medicine for them is so great that it really takes a social worker to come in and help tease that apart and help us get the patients what they need. You can prescribe things all day and set up every appointment under the sun, but if they can't afford it, they can't get to it, they don't know what exists by helping, you know, with the social worker helping with that piece, you're not really going to get anywhere. That's why the social work piece is so vital and unique as well. So I think together, that's what sets the GRACE model apart from other care management programs.
So we've talked a lot about kind of where GRACE started out, so the roots of it, or the underpinnings of the model and the base, and then shared with you some of the replications that we have done to date. And just want to say that I think that the GRACE model has a tremendous amount of applicability across the board to systems both big and small, urban as well as rural. One of the things about GRACE is that because the model key components can be implemented, I think, in pretty creative ways. We are sort of looking at sort of opportunities to use telehealth, certainly recognizing that, particularly in rural populations, that it can be very difficult. There's a lot of windshield time getting the teams out there. We have worked in health systems where they have had people geographically placed throughout the region, and so their team conferences are done virtually because they're, instead of having the team kind of all coming from a central place, but really trying to get people out there and closer to the communities. The use of telehealth is another opportunity that we think can help really kind of leverage the teams so that we can have sort of that continued touch that we think is really important, but can be augmented through those virtual connects. And we've also worked with health systems that may not have all the resources to be able to take on the GRACE model themselves, but have worked closely with home healthcare agencies to really kind of leverage the group that's already in the community and maybe doing some home visits, but then working closely with them so that the GRACE team would maybe be employed by the home healthcare agency to collect that information and then work closely with primary care. So we think that there's really a tremendous amount of applicability, depending on the system, and that's really part of what we do here at our GRACE Training and Resource Center, is really to work closely with health systems to identify what is it that is of most concern, where are your resources, what support do you need, and then when we implement the GRACE model, we are very careful to ensure that the model is adapted into your system. We don't come in with a kind of a one-size-fits-all, because we certainly recognize that that's not the best approach, but rather there are those key tenets that we've talked about today, and then the applicability or the operationalization of that then could vary by site depending on the resources available. So on your screen, there's a couple of other replications we've been to. As Carrie's bio said, we are now in 22 organizations operating in 6 states. Our center offers a variety of training and technical assistance, but I know we're running very short on time, so I want to pause there to see if there's any other additional questions that we could help answer or possibly explain. So Kate, can I turn it back to you?
Yes, there is one question that has come through the chat. someone asking if you could just repeat the name of the model mentioned for care management and transition strategies using the social worker.
Oh, sure. Yes, the care transition model that we have modeled is the Mary Naylor model, Naylor. The Naylor model is the use of a nurse, and we have complemented that with the incorporation of a social worker.
Thank you, Dawn. I think we're all caught up at questions.
All right. Well, for the last couple minutes, as I just want to say again, we work closely with each of the health systems. We have an approach called the ABCs of GRACE implementation that really begins to kind of walk you through the steps that we take when we work with different health systems. So starting with just the agree and the build, we come and can help provide the training and technical assistance to get the model up, help you to evaluate that, gather that feedback, and then really help set that program up for growth and sustainability. And Kate, why don't we go ahead and flip to that second to last slide. There's a summary slide. And this summary slide just is, again, as just kind of a summary of what we've discussed today. We really think that, these older persons with multiple chronic conditions and functional limitations, they have a lot of complex healthcare needs, and GRACE is a model that can really help target those individuals by providing a person-centered care plan, help to integrate your medical and social care together. GRACE is evidence-based. We've proven value regarding not only quality of care, but also lower costs. And we have really found it and demonstrated in a lot of our replications that GRACE is scalable. It can work in a variety of different kinds of settings. And we have found that throughout those settings that we all have similar results in return on investment. So I know we're running really close on time, and so I'll pause there to ask any last minute questions, but we really appreciate the opportunity to share with you today about the GRACE model. If you're just interested in any additional information, please don't hesitate to check out our website or contact us directly. We'd be happy to talk with you further about GRACE and answer any additional questions you may have.
Thank you both so very much. At this point, we're going to check the chat. If you have a question you'd like to ask to our presenters, please do enter it through the chat. As a reminder, we have recorded today's session. We'll be transcribing that yet this week and posting it so it's available to you as a resource on Hinnovation for download and viewing. If you have any questions on accessing that recording in the coming days, please do feel free to reach out to myself or our program staff, and we'd be happy to assist you. As a reminder, next month we'll actually be canceling our readmissions and care transitions community of practice, as it falls on the same day as the HIN learning community. This is scheduled on Tuesday, September 26th, and it'll be our in-person event at the DMAC Ed Center in Ankeny, Iowa. Registration should be opening soon, and we hope that you can make it there to join us that day. The focus for the session will be on readmissions and sepsis. With that, I think we're right at 12 o'clock. I don't see any additional questions coming in through the chat. I do want to thank you for joining us this morning to hear more about GRACE Team Care. Thanks and have a great day.